So now we're getting into some very deep paraspinal mapping. Let's see. Here we go. Here. Yeah, no food for lazy man. Why should we always do paraspinal mapping? Well, a 51-year-old man came to my office with pain for 30 years and it was getting worse. He was depressed, he was anxious. On his pain drawing, he had out-of-body markings which suggest psychosomatic issues. Waddell's non-organic pain signs suggest he had psychosomatic issues. He had a disability application and he'd hired an attorney to get on disability. Strength was intact. I had trouble getting his reflexes every place. His spine MRI was perfectly normal. EMG, some polyphasics in the gluteus maximus and the medial gastroc. Oh, what's that? S1. Paraspinal's abnormal. What's that? S1. No, it's not. The paraspinals are not innervated by S1. He had a score, I think his paraspinal mapping score was like 10 or 15. I can't remember. I wish I'd put that number in here. Sural amplitude was low, but he had edema, and his other studies were normal. So I looked at his, what you would call an S1 radiculopathy, and I said, oh my goodness, something really strange is going on here, because his paraspinals were abnormal, and it's not explained by an S1 radiculopathy. Right, S1 doesn't innervate the paraspinal. Oh, there we go, paraspinal mapping score is 18. And look at this, at L5 I mispalpated, all I got was bone. Score of 6 at L4, 6 at L3, 6 at L2. This is diffuse paraspinal denervation. Something else is going on. I did the mid-thoracics, score was 4. So now we have diffuse paraspinal denervation up and down the spine. So we did the diagnostic procedure. Creatine kinase was elevated. Sent him to rheumatology because he had joint and muscle pain, and he died before he could get to the rheumatologist. His muscle disease involved his heart, and he died on me. So I knew what was going on. I knew it was something funny just because I did paraspinal mapping and I didn't act fast enough. His chief complaint, I heard you doing research on back pain and I thought you might have a better answer. Well, I did, but he died, right? You're going to see these cases. So this only takes 5 minutes. We've been through this. I won't go through that. 5 minutes. When we did the study, the research study, I didn't let my fellows know, but I would time them. I just sat sometimes in the room and watched, and it only took them 5 minutes to do paraspinal mapping. This is very quick. Okay. What about bias? You never think of yourself as a biased person when you're doing a test. But we had an opportunity to look at bias. Oh, this is crazy. So we looked for differences between doctors and differences between a masked and an unmasked doctor. So you are biased. The University of Michigan's laboratory, of which I'm part, but separate, found 1+ positive waves in people with pure S1 radiculopathies. But remember, we talked about it a little bit. If there's an S1 innervated multifidus, it would originate on the S1 spinous process and go down to the S2 spinous process. There's no motion there. It doesn't make any sense. We also have dissected cadavers and not found any S1 innervated multifidus. And in our clinical trials, we never have seen a person with a statistically significant paraspinal finding with an S1 radiculopathy. But at the University of Michigan laboratory, before I did this study, my colleagues found it as much as they did anything else. They kept looking till they found a train and called it, right? So there's a bias that we see there. Come on now, thing. Yeah, so this is kind of goofy. We looked at a single level paraspinal mapping as part of our research protocol. Basically, the unblinded electromyographer who knew it was back pain or asymptomatic or stenosis would do one level EMG just to get the patient used to it so that the blinded electromyographer didn't have a patient jump off the table and be surprised, right? So we had this opportunity to look at the unmasked doctor, masked doctor. Now, the unmasked doctor who thought the patient had mechanical back pain also probably thought the patient would have a normal EMG. And their mean scores were 1/4 the score of the masked doctor. So the fact that you think it should be normal means that you come up with a lower score. It's a bias, okay? This is my favorite study. These are all my friends. These are all the doctors who did the test, okay? I was number G, and I was glad to know that when somebody else did a test at one level and I did a test at one level, on the average, we were in agreement. This one here, C, his scores on the average were 1/3 of mine. This is Hank. Hank is a brilliant, obsessive, compulsive, detail-oriented doctor who's very conservative. Where's Tony? This one is Tony. Tony's now the president of the American Board of Physical Medicine Rehab, and he's quite the politician. And so we're looking at personalities biasing us towards how we call our scores, okay? Unavoidable. Well, it's not. When we took a look at paraspinal mapping, we were pretty good despite those frailties. When we looked at fibrillations, there was a bias where the limb exam on back pain patients was biased in one direction or not. In stenosis, we weren't so sure. Motor units were really pretty, how do we say, dicey, not so clear. A lot of asymptomatic volunteers were reported as having some polyphasic motor units in 2L5 muscles. Now, is that because asymptomatic people have hidden L5 radiculopathies? Or is it because my friends and I are all looking at L5 and expecting polyphasics when we don't know what the answer is? There's a bias there in the limb exam that's much more than the paraspinals. And it matters because we were able to calculate with our different biases, we could correct for those biases. And when we corrected for the biases, the relationship between the score on the EMG and walking improved. So when you get rid of bias and you follow the rules as carefully as you can, you have a better correlation with the actual patient's clinical presentation. Follow the rules and be more right. Fear woman and save your life. This young man was getting married the next month and he thought that was pretty funny. What about localizing a lesion? Well, we did 1 week study. It's actually very difficult because high lumbar radiculopathies are uncommon. Maybe only 5% of disc herniations are at an upper lumbar level. But we collected a bunch of them, and we found that in the S column, the score at the level of the lesion was greater than the scores below the lesion. And remember, the muscle tapers down. I'd expect some abnormalities below the lesion, but not above the lesion. So that is what we found in a small population. Even the mixed, that should be mixed. Even the mixed had that kind of a change where when you get a couple levels below, it's perfectly normal. These that were above the level were actually related to one case where probably there was mispalpation because there's a perfect paraspinal map, but it was just one level above where the MRI showed the herniation. 66-year-old man with low back pain, neck pain, stocking distribution, sensory loss, sural amplitude of 1.6, that's low. Peroneal motor amplitude of 1.2, that's low. The limb EMG, did we just lose, let's see.
Just push the button.
Yep, hello, back again, good. The limb EMG was pretty normal. The first dorsal of the foot was abnormal. Looks like a distal axonal process, right? But now look at your paraspinal mapping. It's focal. It's just at one place. Okay? Now you don't routinely test the iliopsoas, I bet. And maybe in L4 you maybe test the vastus medialis. You would miss all the L2 through radiculopathies. And by the way, the iliopsoas isn't so great anyhow. You'd miss them all if you didn't do paraspinal mapping. So this person, we had all the evidence for polyneuropathy. They had a polyneuropathy. But then when we got to the paraspinals, we mapped this out. We went down and found 2+ positive waves in the adductor longus. So it's a good case. It says the paraspinals will, we keep losing power here. Hello, 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 come in, yes. The paraspinals will find things you didn't expect. Okay. Polyneuropathies have homogeneous diffuse paraspinals, and stenosis or disc herniations don't. 51-year-old man with pain relieved on injection of the facet joints. Somebody did radiofrequency. Do the pain doctors here do radiofrequency ablation of the facet joints? Anybody know? Do they do this? So if the facet joint hurts, you do a block, the pain goes away for an hour. That's diagnostic. If it doesn't work and it doesn't last, then our doctors will often do a radiofrequency ablation of the facet joint nerve, of the posterior primary ramus. That posterior primary ramus goes to the facet joint. It also goes to the multifidus, okay? So this person followed all the rules. They did the radiofrequency rhizotomy, and it didn't help, even though the tests show it should. We did paraspinal mapping, and this looked denervated, and that looked denervated. But somewhere around L4 and 5, the radiofrequency actually failed to denervate. So they went back on and denervated it again, and then it worked. So if your pain doctors are doing radiofrequency studies, you can actually show them that they missed or hit by doing paraspinal mapping after the ablation procedure. Okay, back pain. Kind of tight down here, huh? Kind of ugly and kind of tight down there. Oh, I think this is, I think I've told you this case. Oh no, I haven't. So this is a little bit later. A little kind of tight canal, pretty tight over here. 2002, asymptomatic subject with a negative EMG. 2003, they were an asymptomatic subject with a negative EMG. When they came to us in the clinic, despite their MRI, the only problem they really had was a tender sacroiliac joint. So this isn't the best picture of it, but a radiologist reads this as stenosis. They have a mechanical backache. The MRI is to be ignored. And the paraspinal mapping, I think the point is that false positives are pretty rare. 71-year-old with radiating low back pain. Look at that very tight canal. Nerve conduction studies are normal. Paraspinal abnormalities. Paraspinal abnormalities at L4 and L5. An epidural injection helped. Surgery caused long-term relief. The point here is that your limb examination will miss radiculopathies, right? 40% of stenosis is missed on the limb exam. This person, I'll bet you've never seen this. Well, wait. Jim Albers is a neurologist at the University of Michigan, and he's pretty famous for some of his work. And he's a wise old man. And Jim would say this. You'd say, Dr. Albers, have you ever seen that? And he'd say, I might have seen it, but I never noticed it. And this is the problem. You have seen this perhaps, but you probably have never noticed it. This man had an aortic aneurysm, had surgery, woke up with severe back pain. They got an MRI. A couple days later, had a disc herniation. They said, once you recover from your aortic aneurysm, you should get a disc herniation operation. When he came to my office a couple months later with severe pain, he said, oh, and by the way, doctor, I can't feel along my back. What innervates the back sensory? This is his MRI, which at a different level showed a herniated disc. But look at the paraspinal muscles. Look at the iliopsoas, which is black up here. And look at that multifidus, which is white. Really ugly looking, if you ask me. Later on, I drew lines around it on the left, on your right-hand side. But you see this line in the MRI? This is back muscle rot. This is compartment syndrome, paraspinal compartment syndrome after aortic aneurysm surgery. When you think about the innervation, the posterior, the ventral ramus goes down this way. The posterior primary ramus comes back to the multifidus, and as I said, it goes to the facet joints. So the facet ablation goes for this little branch. That intermediate branch goes to the longissimus, and the lateral branch goes to a branch of the iliocostalis and out to the skin. So when you have paraspinal sensory loss, something is getting the lateral branch of the posterior primary ramus. And in this case, it was a compartment syndrome. Paraspinal sensory loss is pathognomonic. There have been, this is a new case, we've now had a case of this from somebody who had aortic surgery, somebody who had renal surgery, and I forget the third operation where we've seen this paraspinal compartment syndrome. And there are cases of many, there are dozens and dozens of case reports now. What does an EMG look like? Well, what does an EMG look like in a compartment syndrome? On the outside, there were just dense fibrillations, 4+ positive waves and fibrillations. You get to the center of the muscle and it's silent because it's dead, right? His back was contracted. He had Volkmann's contracture of his back into extension, and his pain was because his facet joints were constantly being loaded. He could not flex forward because of the contracture of his paraspinal muscles, right? So sometime you'll be doing an EMG and you put a needle, and now that you know how to get a needle into the multifidus, you'll start saying, oh, where's the muscle? I missed the muscle, or a little bit of muscle, and why shouldn't I keep getting it? Until now, I suspect that you were like me, and if somebody's very obese, you go, oh, I just missed. I'll find another place, right? Now your needle goes in, hits bone. It confirms that you're in the right place. And if you go in, hit bone, and you don't hit any muscle, there's something pathologic going on there. And you'll begin to recognize this, okay? This person has back and bilateral leg pain. EMG is positive in the tibialis anterior, extensor hallucis, vastus medialis, 4, 5S1. Tensor is normal, the sural is absent, peroneal low amplitude, H is absent, F is absent. This is our lady with Charcot-Marie tooth. Her MRI looked pretty tight, looked surgical to me, but she really had Charcot-Marie tooth. And this is not a good picture of what I want to show you. I lost the good picture. This man came to me, he was a former professional tennis player and played on the senior circuit till he was in his late 50s. And he's now 70 years old, and he says, doctor, I walk a short distance and I have to stop and rest. I can't even play tennis anymore. Oh, how far can you walk? Oh, I don't know, maybe 20 meters, and I really got to quit. Spinal stenosis, right? His canal was huge, if it mattered, 20 millimeters, which is abnormally large, if anything. That doesn't matter. And by mistake, I looked at the paraspinal muscles. This isn't a good picture. Again, look at the iliopsoas. Look at the paraspinals. They've been replaced by fat. Now, does anybody know a disease that causes muscles to be replaced by fat? Think of young boys with Duchenne muscular dystrophy. This is a myopathy of the paraspinal muscles. It's now been, we did the first EMG reports of this, but it's been reported before. It's called the bent spine syndrome. And basically what happens is the reason why he starts to fall forward is because he doesn't have enough muscle to hold himself up. It's not because he has neurogenic claudication. It's because the 10 muscle cells that are left get tired, okay? And if you do spine, in my clinic I see spine every day, you'll see a case of this 5 times a year. You will see it. All you have to do is make sure that you also look at the back muscles on that MRI scan. You'll see a case 5 times a year. It's not rare, it's uncommon. And they present with backache, and people say it's mechanical or something like that. It's actually just a lack of back muscles. I think I have a picture here which emphasizes, come on now. Yeah, so like a myopathy, he had decreased insertional activity. He had some peripheral myopathic motor units. We got rid of his hip flexion contracture, and now he could walk normally. The kids or the adults with myopathies, they walk like this, don't they? And the reason why, you say, is because they've got weak gluteal muscles, right? And if they have strong gluteal muscles, they can walk bent forward and pull themselves. Well, it's also because they have weak paraspinal muscles. Now, the bent spine syndrome does not affect the gluteal muscles, it's just the paraspinals. But when this old man could finally come back like this, he could walk as far as he wanted. I mean, if I gave him a bowling ball, he'd go poof and fall. But he could walk much better because we corrected the mechanical disability that you see in myopathies. There's the picture, right? If his body is backwards, he can walk. If his body is forward, he falls to the ground. Cut 1 or 2 more cases and we're done. This person has back and leg pain. L5 radiculopathy on EMG, but the leg pain is at 3 miles, at 5 kilometers. His back pain was mechanical. But if the surgical house officer asked, do you have back pain? Yes. Do you have leg pain? Yes. Does it bother when you walk? Yes. Does it stop you from walking? Yes. 5 kilometers. His back pain wasn't from stenosis. And he again had my hip flexion contraction. Maybe there's a little theme I'm throwing at you here. So here's our bottom line, that paraspinal mapping is the best test for spinal stenosis in terms of sensitivity and specificity. It detects these other things. It can differentiate some polyneuropathies from radiculopathies. And if you don't do it, you will miss some interesting and serious diseases. And there I am, sleeping in some bus with some students. Final case, low back pain. 36-year-old male office worker, left-sided back pain for 3 months, to the thigh, not at the knee. Negative history for neuromuscular disease. He was tender laterally, worse on extension, so it's not like a facet joint. The examination is fine. MRI shows degenerative changes. Paraspinal is abnormal. Medial gastroc, all the S1 muscles are abnormal, but you already know that's not correct. Paraspinal mapping. Thoracic paraspinal is abnormal. So we couldn't figure out what it was. And we did a biopsy of his paraspinals. And what we had is a mitochondrial myopathy. And I think the point is, now that you know how to do the paraspinals, you're going to find these cases where there's diffuse paraspinal abnormality that you never noticed before. You've never looked for it before. And now there are a bunch of cases where I just don't know what's going on. There are a bunch of cases where you find things in the paraspinals, they're up in the thoracic area, and you know, this person had a mitochondrial myopathy. It's been reported in other cases, but there are a lot of other things we don't understand. Nobody has done paraspinal mapping in 10 diabetics. Nobody's done paraspinal mapping in 10 people with alcoholic neuropathy. Nobody's done it with any myopathy. Because of my practice, which is musculoskeletal, I don't do nerve diseases. So if you folks can collect 10 people with some disease and quantify their paraspinals, it's a publishable paper. And it's important to us because we don't understand what's going on with diseases in the back muscles. So I believe, yeah, okay, I'm overkill. Take less time than typing a report. You can use it to validate your parking stubs. No. Sensitive and specific, kind of like those surgical doctors. They're very sensitive. Localizes lesions like a GPS. Like your mother, paraspinal mapping picks up things that you usually don't. Your mother picks up your bedroom when you make a mess. And your attending doctor probably doesn't know how to do it, so this is a great chance to make the teachers look dumb. That was a long morning and you were all awake. Thank you. Again, more questions and we'll do some demonstration this afternoon. Are there other questions?
Maybe, I just have a question. Maybe, I don't know, maybe it's going to be on a workshop. Maybe we will try to draw the column specific mix.
Yeah, we'll do that.
To understand, and maybe some cases, for example, you saw this on a specific, you did not see this on a mix. Yes. I don't know. Or are you going to do this on a training?
I really intend to do that during the workshop. I thought when people had lunch and waited and we got through all this talk, that we'd do it in a very practical way during our workshop. Is everybody here for the workshop too?
Ну, смотрите, я еще раз попросила его, потому что, в общем-то, то, как он проводил этот воркшоп на Американской академии, да, это мы все рисовали, сначала вот теоретическая часть, все это было, правда, 1,5 часа. Полчаса нарисовали, показали, быстро сообразили, а потом были клинические примеры. Что мы нашли, потыкали все. Вот я сейчас у него спрашиваю, либо мы сейчас, у нас до перерыва есть еще полчаса. Он говорит, нет, я буду это делать на воркшопе. Все ли будут на воркшопе? Не только рисовать, он просто приводит клинический пример, рассказать, да? Okay, maybe не все ж будут на воркшопе.
Questions, yes.
Нет?
Ну, наверное, не все.
Не все. Может быть, все-таки что бы хотели, да. Еще раз, чтобы он эту картинку, может быть, вернул, где вот разные мышцы, где какие колонны, куда нужно попасть или что.
Да, не
How
вопрос.
can we be sure that we found the specific muscles or not?
I will answer the question, but then in the demonstration, it's very important. You can get good at palpating, okay? Maybe when you were medical students, they said you feel the iliac crests and make a line across to see where L3 is. You don't do this. The sacrum is a triangle, and when you palpate, you can find the top of the sacrum, and that is very helpful. And then you feel spinous process and another and another. And again, we'll show you this afternoon. But when your needle is over the sacrum, the muscles are very shallow. And when you get over L5, the muscles are deep. So if I have my needle here, and I'm inserting paraspinal mapping, I insert maybe a half centimeter, looking for insertional activity. When I'm over the sacrum, maybe I go through fat, 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 fat. In Americans, a lot of fat. Then I hit muscle, go right? Motor, some electric sound. And then I hit bone. Well, there's only a centimeter of muscle. Okay? Another time, I go further up the spine. Fat, 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 fat. Woo! I went 2 centimeters. Now I'm not over the sacrum, I'm over L5. Okay? So first of all, you use your palpation skills. And second of all, while you're testing, your EMG needle can tell how deep the muscle is and whether you're over the sacrum or not. And third, if you're wrong, well, it only matters if you're too cranial, if you're too high, because L5 is the most common radiculopathy. So if you're not sure or you think you're wrong, you go down even one level below, one level lower, and be really sure you got L5. Okay? I tell people, you know, all of you have an ultrasound machine in your EMG lab. Did you know?
No.
Oh yes, yes you do. Yes you do.
But we don't have.
Yes you do. Yes, they all do. Because what you have is you have this thing that knows when it's in fat, it knows when it's in muscle, and it knows when it's in bone. Huh? So your needle goes through fat, muscle, bone, and you can tell how deep different tissues are, right? So when you're over the sacrum, you just have a little bit of muscle before you hit bone. When you're over L5, you have a lot of muscle before you hit bone. And it's amazing when you actually do this, and when we do it this afternoon, you'll see that I can tell that I went off the cliff, I went off the edge. That's how you can be sure. Mm-hmm.
I was asking about this picture.
Yes. Yes.
Maybe we will repeat again.
Mm-hmm. Should I right now talk about this?
Please.
Okay.
5-10 minutes.
Of course.
About specific, about mixed,
Yes.
and what we should what we should look for in a stenosis.
Right.
The both or only specific?
No, both, because the total score comes from both.
Mm.
And you have to do it anyhow. You have to get the needle to the specific
Okay,
anyhow.
and another question.
Yeah.
If we will see only in a mixed column, so after that what?
So that's a very good question, so I want to be careful. If your total score is abnormal, it doesn't matter where you found it. It's an abnormal test, okay? If it's only in mixed, you're a little cautious about saying which level, whether it's L5 or L4 or L3, a little cautious. It turns out that, especially in the lower lumbar area, the mixed column is actually pretty specific. That's very complicated to tell you, but when you think about the spine bones on top of each other, right? And you have spinous processes in the upper lumbar area, the...
We can draw.
Yeah, oh, that's a good idea. Yeah. Good. This is good. Let's see. I hope you can all see.
That's what I want.
Okay. I did not go to art school. This is the best you can get from me. Okay, here's the bones. Oh, this is good. So I'm kind of, let's see here, green, red, okay. So, I'm going to draw two pictures here.
Okay.
Okay, here's the skin. Okay, so the multifidus from L5 goes from the bottom of L5 and it goes down over an area like this. Okay, the multifidus from L4 goes from the bottom of L4 and it goes out to this transverse process and also comes down something like that. And the multifidus of L3, bottom of L3, down 1, 2, and maybe gets a little bit down here, it doesn't matter, okay? So the concept of paraspinal mapping is that if I stick a needle into the L5 bone and hit the bone is electrically silent. The next muscle out is L4 multifidus, and that's in the specific column, that last centimeter. On the way in, you'll go through some L3 and maybe even some L2. So let me come back here. We'll go back and forth to try to answer this question. So if this is the L5 bone, okay, the L5 multifidus is down here. You won't see it. The L4 multifidus, I'm not going to be color-coded here, is probably like this, okay? The L3 is probably like this. And the L2 is probably out here someplace. And the longissimus is, I should have made it colored. Oh well, let's see.
Понимаете, да, что на этом уровне, на уровне пятого позвонка, он сейчас идет послойно, что он видит на остистом, если он к остистому отростку подойдет. Мы там увидим и со второго корешка мультифидус, и с третьего корешка,
So, if I
и
take
с
my
первого лонгиссимус длинную.
So if I take my needle 2.5 centimeters and I go at a 45-degree angle, or even steeper 60-degree, well, okay. When I hit bone, I'm in the L4 multifidus, the L5
Если он
bone.
дотронется до кости, он точно в мультифидус, которая, нет,
This is the
четвертый корешок.
last centimeter. On the way in, I get valuable information from L3 and L2.
А просто выше, там уже L3 может быть, и L2 уже там же по сантиметрам не посчитаешь.
Now, on the way in, I don't know if I'm in L3, I don't know if I'm in L2, but on the way in, I may find denervation. And at L5, in this particular human being, I also happen to pass through some longissimus that may have denervation, and some iliocostalis that might have some denervation. So the mixed column could have some other stuff that, well, it's part of the protocol, so we just don't throw that data out. Okay? Now, here's what really happens. The multifidus mass, and you can see this on the MRI scans, or you can see this if you dissect a cadaver, it kind of goes like this. Okay? This is the mass of the multifidus. And so up here, you really will go through some longissimus or some iliocostalis. But you get down to the lower area, and you're more likely to just go through more lateral multifidus, which is still useful information. So the lowest lumbar area, the mixed column, probably is still multifidus. It's just from a level above. In the upper area, you may get some junk from the iliocostalis or the longissimus because the multifidus mass is a little bit skinnier. Okay? I'm thinking that also to answer the question, I should walk through the protocol one more time. And we're going to do it in the room over there again, okay? So this is very, very simple. What am I going to use? I'm going to use red.
Просто он говорит, он потом опять это объяснит как помочь. И ему потом нарисую. Клинический пример надо просто.
Feel the sacral base, okay?
То есть мы оцениваем сантиметр, да? Вот достиг, все.
You feel the spinous process.
Главное вкус
Вообще
попасть,
вот
чтобы быть
обо мне
уверены, что мы на
рассказывать.
том уровне. Если мы правильно все нащупали, конечно.
So I feel the spinous process. I go 2.5 centimeters to the side. I go over the sacral base 2.5 centimeters to the side. I go next to this one. I go next to this one. Those are my 4 places that I will put my needle in the skin.
Or 2.5 centimeters from the
midline.
The middle line.
And now I'm going at a 45 or 60 degree angle, okay? But I put my needle in, insert, 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 and that comes up with the score. I need to draw my score sheet.
How many times you need to put in the needle?
Needle goes into the skin 4 times, but at each spot it's directed in 3 directions. So 12 insertions to the tip. So now this is where we'll come back here. So here I am at L2 multifidus. This is the L3 bone. This is the L2 multifidus, and that will be scored up here. Okay? Now I'm going straight across, or I went straight across with my needle. Whatever I find there when I go straight across will be scored in the part that looks straight across, right here, okay? And anything I might find on the way in gets scored in here. Anything I find in the last centimeter before I hit bone gets scored here. And I'll demonstrate. So I go insert, insert, brrr, train of positive waves. First question, did it last a second? Yes, it did. Yeah, okay. Well, then I can back up and try again. Nothing. Back up and try again. Brrr. Oh, it reproduced itself. Just one train, that's a score of 1 plus. Was I within a centimeter of the midline? Was I in the S column or the M column? Maybe I'm not so sure. Maybe I'm not so sure. But if I keep inserting, I'll know, right? So I insert one little bit and I hit bone. Well, I must have been in the S column, right? So this person has a score of plus in the S column going straight in.
Plus, this is in a one
One
place.
plus
in
in one place, yes. So let's go now. I pull my needle out to the surface.
Excuse me, it's like on a Preston scale.
Yes, a 0 to 4 plus.
It's exactly Preston scale.
Just about. I would say yes. Okay. So now my needle's still in the skin. I pulled out to the surface, and I'm going cranially. Insert, insert, insert. Train of positive waves. Another train of positive waves. Ooh, 2 different trains of positive waves. I don't even have to reproduce it. That's 2 plus. I keep going, and I realize that I found it there, but I'm more than a centimeter from midline. So now I have a score of plus, plus. I'm on the top. I'm going upwards. Plus, plus, going upwards, and it was normal going inward, okay? And then I come back again, out to the surface, and I go down, down, nothing, nothing. Reproduce. Yep, okay, that's a score. I'm within a centimeter. I got scored here, and nothing here. So this person has a score at L2 of 1, 2, 3, 4. Okay? Right? Again, when we demonstrate, this is going to be very easy. It's hard to talk on paper and not see the body. Okay? So we'll continue doing this at different levels. If I found the baseline filled with positive waves and fibrillations, I couldn't see baseline, then I'd get a score of, 4 plus, right? If I find a number of them, I'd call it 3 plus. So
if you will find like that,
yeah.
For example, let's say the same.
Yeah.
Okay.
Yeah.
And here.
Yeah. Yeah.
What is that?
Right. So
Well, it's a big score, so
it
maybe
is.
one, two.
Yeah. So what's the score? It's 4 at that level. 1, 2, 3, 4, 5, 6 at this level. 1, 2, 3, 4 at this level, and 0 at this level. Okay. So first of all, your report says abnormal EMG, paraspinal mapping score of 14, which is very abnormal. There's something that's pathologic happening, okay? The second question, and the way you drew it is actually complicated because it's confusing me that
okay,
L5...
just put plus on a 5.
Thank you, because you understand. So I go plus, 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 plus. This is 4, total score is 18, okay? This is not focal, right? You have scores at every level, okay? Now, it would be really rare for somebody to have lumbar stenosis at L1, because that's right where the conus medullaris is, right? That'd be really strange to have L2 involved in spinal stenosis, okay?
But it could be.
It would be so rare that I've never seen it in my life. That's how rare it is, okay? What is not rare is diffuse problems that affect the muscles, right? So I would go up to the thoracic area, T6, and I get a score, we cheated. I get a score of 4, okay? And now I'm looking at something wrong and it's not in the back. It's not a spinal problem. I don't know what it is on an EMG. If it's a simple, like a statin myopathy, you might well find myopathic motor units in the gluteus maximus, right? But we're finding, again, we'll find this in people who we don't have anything else to find except the paraspinal denervation, and that's sometimes polyneuropathies that we can name, sometimes it's myopathies that we can name, and sometimes I don't know what it is and I haven't done a biopsy and I probably won't on that person. Right?
Okay, if it could be not the second one, not the 5, and you will see the changes on the 3 and 4.
Yeah, like.
It could be stenosis, could
Oh yeah, oh yeah. Like for instance, you'd have a score like this.
This is the left side or this is
The-
the
just-
same side?
Done with that
Okay.
side, okay? Something like this, okay? Score is 3, 1, 2, 3, 4, 5, 6, and everything else is negative?
Mm-hmm.
Yeah. That's a focal lesion. Is it just L3 multifidus? I don't think so. I think it's L3 and L4, okay? And then, with humility, you could be off by palpation by 1 level, right? I mean, you get good at palpation, but is it 3 and 4? Yeah, I think so. So I would probably call that focal abnormal paraspinal findings consistent with radiculopathy, suggesting L3 and L4. If the limb didn't show anything else, that would be my report. I'd be a little bit vague because since I invented it, I'm more cautious in saying, I know it's L5. So I'd say it's abnormal, looks like L3 and L4, but no limb findings to need some correlation there. Mm-hmm. Now, once you have this, now you can look at an MRI, okay? Abnormal, where is it happening is what an MRI is useful for, right? And if you've got a perfectly clean spine, except for at 1 level, you feel more confident what's going on there.
So the third question is it real, the same question. We did not find nothing in multiphysics.
Yeah.
And we find something in the mixed column.
Yeah. Abnormal.
Why do we need, that's what I want to
Yeah.
why do we need so badly we need this multiphysics? Because this is really
Yeah.
specific for the level.
For the level, and also the S column is clearly multifidus. The M column might be multifidus, or it might be longissimus iliocostalis. I don't find what you're saying very often. I do find it, but it's very uncommon. If I just find something in the mixed column and it's statistically abnormal, right? If I find one train of positive waves, that doesn't bother me because that's normal, if that's all I found on the whole test. But if I found somebody who had, we use blue, right? And you found like, and everything else was normal, I don't see that often. I don't know what to say, except that that is statistically abnormal. I don't know what that is, but I still, without any experience, because I don't see this enough to tell, I still call that abnormal because for a young person, a score of 4 is abnormal. I don't know what to say about that. It's a good question, but it's an uncommon presentation.
Thank you.
Да, можно? Можно на русском сначала, может, я не понял до конца, как считается спонтанная активность? Вот лектор сказал, что 4 плюса, для этого надо сделать хотя бы 4 вкола. Я так понял, для каждого уровня мы делаем всего 3 вкола. То есть это надо делать или больше вколов, и имеет значение в каждом коле есть-нет спонтанной активности, или насколько она выражена.
It's a question again about the scale of the spontaneous activity. Breast or another scale? You have a slide.
I do. It's on slideshow number
Another presentation.
3,
Maybe we
number
will
2.
draw how do you put 1 plus, 2 plus, 3
Yeah.
plus.
Let's see. Okay. So 0 means I didn't see any activity at all. I hit bone by mistake. I was in the wrong place. The patient didn't relax. 0 means bad test. Okay. Dash equals normal. Okay. So dash, 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 dash. 1 plus means you have to have 1 fib or positive wave. It has to last greater than 1 second. And it has to be reproduced. And you have 2 or fewer trials. So again, it's very conservative. This is the most important part. So I put my needle into the mixed column at L4. If I put my needle into this area here, I'm not in the last centimeter. I find a train of positive waves here. It has to last 1 second. It's still normal unless I come back and insert into that area again and insert again. And of those 2 extra insertions, if I find it again or find another train of positive wave, only then do I have a score, right? So, and again, when I demonstrate it, I think we'll see this easier. It's really hard to talk on paper when a needle in a body is very simple. So it has to be reproducible, and you can't keep looking and looking. You only get 2 chances to reproduce it. If you can't reproduce it, it's still minus. It's still normal. 2 plus is either 2 different waveforms in that area or 2 different areas within that area. So here I am back at my spot here, and I go in and I see a fib, and I see I see a fib, and I see a positive wave. 2 different waveforms. That's automatically a 2 plus. I don't even have to go back and look. It's already there, okay? Or I'm out here and I see a train of positive waves, and I go another centimeter in. I'm still in the mixed column, and I see another train of positive waves. 2 different locations within that box. That would be 2 plus, okay? So sometimes I'm testing and I just know it's going to be abnormal. So I poke, poke, find a train of positive waves, poke, poke, find another one. I don't even have to go reproduce it. That's already a 2 plus score, okay?
Здесь просто переведу, очень сложно. Почему у него спросила про Престона шкалу? Они отталкивались от нее. 2 плюса по Престону это больше, чем в 2 местах. Вы нашли в 2 разных, там продвинулись, опять нашли. Но он еще по-другому говорит, если он находит их разные.
По
Господи, кто
морфологии.
там на экране смотрит по морфологии, как я не раз.
Конечно,
То
нет.
есть все-таки...
Ну, это говорит о том, что это значит два мышечных волокна страдают, по
Ну,
сути.
поэтому
Или-
то, что там будет рассказывать морфологию. Так, we understand.
Okay. 3 plus is vague. And the only reason we have 3 plus is because I want to follow Dalby or Preston and Shapiro about 1 to 4 plus. So 3 plus means more than 2 plus. It's a very sloppy definition, but it's there. You get a few different waveforms, you'll call it 3 plus, okay? And 4 plus,
Много. Во всех
То
местах.
есть это все полуколичественная оценка. Это на глаз врача.
Ну, это просто на глаз врача, это его шкала, да.
and 4 plus means you can't, there's no baseline.
Ну, как
А,
у него,
вроде
ничего
всё.
уже, все
Все время шумит, короче.
Да.
В каждом поле. Ну, она, в принципе, такая же классификация, как и при травме, при виду.
Она одна была. Я очень спасибо, что она единственная первую.
По
вторую.
морфологии единственная.
Немножечко там, у Престона такого нет. Один плюс. Это если вы увидели в одном месте быстро истощающуюся, она ушла, перекололись вы ее опять. Главное, reproducible. Опять увидели, она убежала. Вторая в 2-3 местах.
I'm very aware that this looks confusing to you. When we do it on a person, it'll be really simple. It's just not that hard, but I don't know how to speak about it without actually showing you on a person. So don't be too lost. If you will do this, it'll take you 5 minutes.
Yeah, that's what really confused us,
Мгм.
и, наверное, и вас, и меня confused еще там в Вашингтоне, что, в принципе, когда он рисует вот эту шкалу его, да, то вы можете не ставить эти плюсики, вы можете поставить 4 плюс, 2 плюс, yes? We can change it.
Yeah, yeah.
That's why we were confused.
Ah,
So
okay.
we had to do
Oh, no.
That's what the question.
I see, yeah.
So the doctor asked, we have to put all the time to find the 4 pluses.
No. Just
So мы можем поставить 4, но это первый раз я к нему так-то там еще мучила его.
So, this is my patient. I'll show you, okay? I palpate, I mark, I palpate, I mark, I palpate, I mark, I palpate, I mark. I take my needle, I go pop, 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 pop. And in a normal person, in a person with no abnormalities, I'm done. If they got no abnormalities, I'm all done. That's all it is. It's very quick. Maybe a few more moments. When you find a score, you have to do a little bit more thinking.
You know what, I will translate it. У меня есть в печатном виде с воркшопа, его одно на английском языке, понятно, там на 4 листах, вот с такими же рисуночками, совсем распечатка. Я передам или Альбине Игоревне, или Валентине Николаевне, есть адреса, вам перешлют, там легче будет разобраться. Там и этот скор есть, это
Вообще оно есть
шкала.
в свободном доступе в интернете.
Да, его можно и в
Но
PDF
этот,
найти, как только вы
paraspinal
наберете
mapping
paraspinal mapping Haig,
Да.
она сразу вам выскочит. Да, это даже, может быть, и не надо пересылать. Найдете за... I'm talking that you have the very nice presentation, and we can just Google paraspinal mapping Haig, and we will see. I'll show you.
Oh, really?
I'll
Did
show
you find it somewhere?
Yes.
I didn't see it. Really?
Where? Ну,
А.
всё, наверное.
Ну, всегда надо ли смотреть без стороны, да? По сути.
Should we look on a both side always?
Good question. Usually, just one side answers the clinical question. A younger person with symptoms in one leg, and you do an EMG and you find a radiculopathy, that's great, okay? It is people with spinal stenosis, well, if you need to be the clinician, not just the tester here. If your only question is there spinal stenosis, and you find abnormalities on one side, you've answered your question. But if your question is, what levels are involved and why are there symptoms on both sides, then you might do both sides. I would say that in older people with a question of spinal stenosis, I usually do both sides because stenosis is a central phenomenon. But you wouldn't have to. If you just did one side and found your answer, then that's fine. If they're very symptomatic on the right side and you test the right side and it's normal, I don't think you'll find something on the left side, so I would just test one side. Yes?
Any complications during this
Я до сих пор
procedure?
его вечером, пока будем ехать, замучаю.
The question was, are there any complications during this procedure? Absolutely, positively not. For 25 years, every time I've given a talk about paraspinal mapping, and sometimes it's been to 500 neurophysiologists, I'd ask the audience, has anybody ever seen a complication from an EMG besides a pneumothorax? Right? You won't get, right? So it's been 25 years, and pneumothorax, somebody got superficial phlebitis, no other complication in the world ever that I've seen in the literature or that I've seen by asking thousands of doctors. So you would think that maybe some bad medical student would cause a spinal infection or a cerebrospinal fluid leak or nerve damage. It just hasn't happened. So I think it's a very, very safe test.
How about neck?
Also, never been a complication in the neck. Never. At one time, I did a very comprehensive review of needle insertions in the neck, and somebody doing EMGs, never a complication except for pneumothorax. There have been a couple of pneumothoraces, right? No other EMG complications. Somebody was doing very aggressive trigger point needling, and they got the vertebral artery and had a stroke. But it was somebody doing this with a needle all over like this. So in terms of neurologic consequences, I worry about it, but the fact is the test has been done since 1940 and nobody's recorded a single case of a complication. So I guess we're okay.
I guess we will be okay too.
I'll continue to worry, but I mean that's longer than I've been alive, you know? Yeah.
Okay.
How often do you use it test for thoracic level?
Oh, thoracic, great question. Well, of course, thoracic radiculopathies are very uncommon. So I don't see it often. So how often? Rarely, because I see very few thoracic radiculopathies. The few cases I've seen, it was pretty impressive. I had somebody with a thoracic disc herniation, maybe clonus in one leg, you know, very clear, mapped it exactly to where the herniation was. I had a couple of cases where it was just impressive, like really right there. I've had one person with, do you know a spinal cord herniation? Where the spinal cord herniates out through yeah, and it picked it up with the spinal cord herniation. So I couldn't tell you sensitivity and specificity. I just haven't seen enough cases. But I've been encouraged. You know, I've found things with focal paraspinal mapping. Yeah. There was another question.
Я там кого-то перебила.
Я тоже хотел спросить.
Да, то же самое, да?
Да.
Thank you very much. Maybe
Еще один.
one question.
During spinal stenosis, we have changes on both sides, yes?
Often, not always.
Not only.
Oh dear. Are you ready for me to confuse you again? So, I didn't talk about this disease either. So 5 more minutes for this question. First of all, there's another disease that people have written about that you will pick up, but I don't quite know when it happens, which is there have been a number of case reports and anatomical dissections to show entrapment of the posterior primary ramus. It goes under a ligament called the mammallo-accessory ligament, And so people will talk about non-radiating back pain caused by denervation of the multifidus. They call it carpal tunnel syndrome of the back. So sometimes when people find focal paraspinal abnormalities, they'll say somebody has this syndrome. I don't know. But a man named Myron Laban wrote about this, and there have been case reports here and there without good science. But I'm mentioning posterior primary ramus syndrome. Your question was, I'm sorry, about
spinal stenosis,
right.
Changes
So,
on both sides.
I always thought that when I found paraspinal denervation, it was because the nerve root was involved. But then we looked at our data, and we looked at people who had, let's say, right-sided leg pain versus left-sided leg pain. And you would think that if a person had right-sided leg pain and not left-sided leg pain, that the right-sided paraspinal mapping would be abnormal, and the left side would be lesser, at least. It's not true. I don't understand. Either it's because stenosis is really central and it preferentially affects the posterior primary ramus. The other theory is, and we did some work about this, that spinal stenosis is a dynamic process where the bones are shifting on each other. When you're, my bones on top of each other, you see my spinal canal, right? If I go like this, I pinch. You see, I close it up. Can you see this? Okay. So when you stand and you walk is when you get symptoms. And so the thought is then when people with stenosis stand and walk, their multifidus muscles relax, the segmental stabilizes, and they shift. Okay. So the thought there is that the shift causes entrapment of the posterior primary ramus, and it is an important test, but it's an epiphenomenon. It's not actually the stenosis, it's the entrapment of the posterior ramus. That's a really tough question, but that's one of the thoughts we have, and it's very confusing. People don't really know about that. Yeah. I don't know about you, my brain is going Good. Is it time for a break? What? Okay, good.
We have a break,
Yes.
lunch.
Yeah, good.
Thank you very much.
Yeah.
You see how many questions?
I love it. This is what we need.